One is flow, is moving people as safely but swiftly through hospital as we can. And I think we need to get best practice from one part of the system to another. I think you might not like to hear this, but I think Surrey and Sussex flow management, the Virginia Mason program, is excellent. And I think we've got to take best practice from one part of the system and encourage people in other parts of the system to do it. Your IMSK program is excellent, but it hasn't been picked up, fully, frankly, or at all by Royal Surrey or Epsom or East Surrey. So, I think the key part of the ICS is to get that best practice, identify it, codify it, create robust operating models, and then determine the metrics and get others to adopt it. And the fifth of the critical five is system-wide efficiencies, which is making sure that we're getting the best patient service across the whole 1.2 million people that we cover at the ICS, and that we are also spending taxpayers' money as efficiently as we can across those 1.2 million people. That means consolidating clinical activity. Where do we do? We do lots of stuff on every site. Should we do less on one site, move some things to a scale efficient activity somewhere else, for instance? I think we need to develop existing and create new clinical networks. We've got a very good cancer network out of Royal Surrey. Growing that is a big priority. So it's a bigger part of Royal Surrey's activity. New clinical pathways. David and Shashi and James will know about the metabolic health initiative that we're talking about at Ashford. So I think we need to be innovative. Whilst it's a tough gig at the moment, it's a tough environment in the system, I think we have got to lift our eyes and aspire and have ambition. You've talked about the Ashford Centre of Elective Clinical Excellence. That sort of initiative, I think, is something we have to drive. So let me stop there, Andy. I think we've got a lot to do. I think we've got one of the best and most advanced systems in the country. I think the cooperation between the hospitals, developing the community is really encouraging. And frankly, I think we've just got to make this ICS work, because it's not working well enough currently for patients or for our workers, for the workforce, nor for taxpayers. So we've got a very important objective ahead of us. So I'll pause there, Andy.
Thank you. Questions for Ian? Marcin?
Ian, thank you. Very clear, and it's the first time I've heard our 5 critical areas. So to me, that was really helpful to hear and listen. I think a lot of us agree with all of that. The big question is that kind of transformation needs investment before you can start increasing the efficiencies and saving the money and moving things about. Where are we getting that? Because the government's not giving us that investment in order to make some of these significant transformations. So where does one start? And then what's your biggest priority, Ian? Thank you.
I think the it's a great question, Marcin. I think we've got to get more capital, outside capital. Capital is constrained only in the NHS. It's not constrained in the rest of the world. So I think we've got to get the money working for us from outside sources. I think we constrain ourselves too often. I think we do have to get efficiencies. I think, Tom, were you talking about it, or David, about the work Jack's doing? The community hospital costs, NHS cost is about £460 a day. And Jack believes, and we're going to hold him to it, that he can get that down to £120 a day by doing deals with people like CDH homes and other care home operators. So we can free some money up. But you're right, Marcin, this is a terribly constrained financial environment, and it is tough. I mean, Simon and you actually talked about the 23 million, and you're one of the lower ones in the system. So it's not going to be easy, but we have to do it. We've either got to relax that capital constraint by getting outside money, or by being more efficient, or frankly asking, and I think this is a key part of the next month's work that Simon talked about, getting some relief from the centre to say we have got really fantastic ambitions. Ashford Clinical Centre of Excellence, metabolic health, cancer. Give us some time and space, because as people have, in any sector, private sector, public sector, a change program like we're talking about here with the critical 5 takes a lot of management time. It takes a lot of money. And, the NHS traditionally tries to do this on a shoestring, which is why we don't get effective change. So it's not easy, but we've got to work through it. David.
David.
Yeah, and I was just going to say, Ian, thanks for coming. And as you know, I agree with absolutely everything you said. And it's not a question of the what or the why. That is really, really clear. It is a question about the how, and it is a question, as you pointed out, which is bringing pace to this. And Martin, you mentioned this. Some of these are really enormous transformational changes, particularly around workforce.
Yeah.
And we do need the capacity and the capability of people to be able to help us manage those really difficult things. Otherwise, as you say, if we manage it on a shoestring like the NHS sometimes tries to do, we will get ourselves in an even worse position than we are now, both with our patients and with our workforce. So we're totally behind you, Ian, and we want to move things on swiftly and quickly with the right resources.
Great, thanks, David.
John?
Well, it's going back to that issue there, which is really about you mentioned sustainability there, Ian, and I think that's the thing about sort of embedding this change, but trying to do it at pace. We spent a lot of time today actually considering, obviously, the Ockenden report and the implications of that within maternity services. And it seems to me that, there's a much bigger issue there in terms of you just don't have the available staff in order to be able to do the work. So do you have any thoughts on that? How do we, conjure up staff, or how is it changing working practices? Is it all of the above?
I think we have got to make it more efficient. Hopefully Cerner, for instance, I don't know what the figure is, Simon, but certainly at King's, when I was chair at King's College Hospital, the average ED consultant spends 10 minutes per patient trying to figure out, the care record and the system. Hopefully that we've got to bring that down to, a fraction of that. And at King's, at least, we worked out that would save us 4 or 5 ED consultants per shift. So I think there are, efficiencies that we can do. Every NHS employee will tell you how often they have to ask the patient their history. How often they're waiting for did not attends. Theatres, you run your theatres a lot better than we did at King's, but at King's we had an average late start of an hour, so consultants just hanging about waiting to go into theatre, for instance. So I think we can do it better. Secondly, I think we can, we should look, I had a period running a care home business, and I think one of the forgotten areas is social care. So there's as many people in social care, in dom care and care homes, 1.5 million, as there are in the NHS. There are 400,000 beds in the nursing home sector compared to 100,000 in the NHS, obviously much lower acuity. But I think getting our health and social care workforces integrated, giving career pathways to those carers who are really good, the dom care, care home carers, work fantastically hard, 3/4 of them on minimum wage, that we can use those much better in an integrated, give them a career path into the NHS or nursing if that's what they want to do. Give people experience of working in hospitals and community in social care. So I think it's a real big problem, John. But I also think, given the clap for the carers and all of that, this is a moment when we need to take advantage of that, because I think people do want to come into the NHS. I think we've just got to give them better career paths and more satisfying jobs and keep them there, but it's not easy.
And I'll take the last one because we're out of time. There are two things really. David and I were in receipt of a complaint yesterday, and it's a young person who's been to our board actually on a patient story 4 years ago, and it really brought to mind your number 3, because now they've transitioned to being an adult. The poor old carer, father in this case, is trying to juggle CCG, hospital, GP, social care, carers, and it's a nightmare for them. And you know, I wept almost when I read it. And we can fix some things in it, but having that, you know, somebody empowered looking after these people, because otherwise he will be in our hospital. You know, it's profoundly disabled, you know, really of need of care. So number 3 to me, you know, makes so much sense. But we've got to invest, as David said to me yesterday when I discussed it with him. It's no good having a band 4 person saying I'm going to coordinate this. You actually need somebody empowered who can make things happen. So it's just a comment really on 3. And the final one was, which really related back to a discussion we had earlier on maternity, is I think we do have to go round the boy again on the release of capital that, you know, particularly for ourselves and Surrey and Borders, we've got sitting in the bank. We sold land with the full agreement of the centre, and yet, you know, we're subject to this. And, you know, our maternity is crying out for substantial capital investment. Now, there is a system thing around, we need to sort maternity out across the system, of course. But I think using the good offices of Ben Spencer, for example, and I know he wrote on our behalf previously, but the MPs of Surrey, we on the back of Ockenden, I think we've got to, you know, pitch for more capital release.
Yeah, absolutely. And well, the SABP is a good example. And you know, unlike many of the London hospitals, we do have land. I mean, you know, you're a bit more constrained, but Sash has got East Surrey. It's got lots of land we can build on, and in fact, we'll do a Surrey and Borders facility there, and probably more. Hopefully, maybe a paediatric centre there. But I think we've just got to take on the system much more robustly, Andy. I mean, Weybridge is another example. I mean, that place burnt down 5 years ago. It was meant to be self-insured by the NHS, and we're still fighting to get the money to redevelop a site that is derelict and has a couple of porta cabins where the GPs are. I think we just can't be, you know, we can't be slow in confronting perverse things that happen in the system, because we are representatives of the patients and our workforce at the end of the day.
Absolutely. Look, Ian, I'd like to thank you for coming first and sitting through the entire open board meeting. Hopefully that gave you some insight as to who we are and how we operate. And thank you for making it so clear. You know, your critical 5 really clear, as Marcin says. And you know, as you well know, our board is hugely supportive of collaboration across the system, and will continue to be. So thank you for that.
Thank you very much.
So any other business? I've not been notified of any. No. So we have had a couple of questions from the public, from Rosemary. I will read the first one out and then ask Tom and James between them to answer that. The question, I know at least one residential care home in Chertsey is being used for step down on a temporary basis to discharge elderly patients from St Peter's. What are the places designated as step down, and what are patients and families being told about the arrangements? I think this is a social care one, as I understand it. But Tom, do you want to pick that up?
James was going to.
James,
pick that up on it. That's okay, James.
Yeah, absolutely. Yeah, so we do have these arrangements, Chair. So this is social care have arrangements for step down beds in some nursing homes, particularly 2 nursing homes that we've used. This was something that was set up through sort of the peak of through the pandemic, because to help support flow. The process is that patients are spoken to. These are patients who are waiting for something, some either support at home or ongoing package of care that's not in place, and they go to step down care, residential care, whilst waiting for the rest of the process to be put in place. And that is explained to patients. It's very specific cohorts of patients waiting for particular things, but it is part of what social care are doing. It's part of the discharge to assess pathway that we have.
Okay, and so I think Rosemary's point was around the Abbey Chase one, so that is one of those, is it?
Yes, it is. Yeah.
Okay. So yes. So social care have done this with a couple of nursing homes. People are told about the arrangements. It is temporary, isn't it? That's
it is. Yeah, we have about 27 beds across those two the care homes for this arrangement. Yeah.
And it's absolutely, we do need to get hospital beds free, as we've discussed today, for people who are waiting for care packages, but we need to look after them safely while they are, and better that they are there than in our hospital. And the other question was an interesting one, which was information advice. What information advice and help is provided for patients to vote in the local elections? Not a question I've had before. And I think, Sal, you'd put something together on this. Is she here?
I am, sorry, struggling to unmute. Indeed, Andy, there are very clear guidelines for NHS organisations, indeed all public sector organisations, around what we are and are not allowed to do in pre-election periods. Some people refer to this as PERDA, and we're not able to publicise or allow any political activity within the organisation. That said, I'm sure that if a patient were to request a staff member to perhaps pop a postal vote for them in the post box, we wouldn't take it to the nth degree, but we aren't allowed to actually ask candidates to or invite them to canvass within the organisation or to display any political information to that end.
Yeah, and clearly, we're looking to their relatives, loved ones, if they want to get them a postal vote. We're hoping that they're not in hospital that long, to be honest, that they would require that. In our case, an acute hospital, that's a very different, Rosemary, I know from your experience with Surrey and Borders, which may have different arrangements, but we would look to move people very quickly through our hospitals. If somebody really wanted to register for a postal vote, then of course that isn't political activity. Then we would help if they had no loved ones to look after them and express that. So I hope that those are the two questions that I'd had from Rosemary. Thank you for submitting those in advance, Rosemary. That's very helpful. I hope those are helpful to you. So at that point, any reflections on today's meeting? Sorry, it has gone over. We've gone over by about 20 minutes, but I think it was a very full agenda today, and well worth going into, particularly the staff survey coming out today, and the quality report in particular needed some really good discussions. So thank you for bearing with us. Sorry for that I've let it go over today. The date of the next board meeting is the 12th of May. We brought that forward because of Surrey Safe Care. Normally it would be the last Thursday in the month. Because of there will be some compromises on data for that meeting, but we thought on balance, and I know you've all been involved in the discussion, better to bring it forward than try and push it back, and definitely better not to have it in the middle of the Surrey Safe Care go live. So thank you for your help, board members. I know we've got the Deloitte well-led review feedback, and I think it's 2:15, Sal? Okay. Thank you to the members of the public, and particularly the governors who've joined us. Always appreciate that. Thank you very much, everybody.
Thank you.